Hello, my name is Dr. Kelly Roof, and I am a clinical educator here at Precision Analytical. And I just want to welcome you to another installment of the Dutch webinar series. So I'm really excited today because today in our webinar, we're going to welcome Dr. Julie Greenberg. And she's going to dive into the root causes of acne and the importance of a holistic approach to treatment. She's going to discuss the impact that Western diets have on the gut-skin connection, but also the significant role that hormones play in acne development. Through a functional medicine lens, Dr. Greenberg will present a holistic approach to acne treatment, underscoring the importance of comprehensive testing and dietary adjustments. She'll also address the profound psychological effects of acne and stress the value of education in functional dermatology for practitioners. We're glad you chose to join us to gain valuable insights into a more effective and integrative approach to managing acne. So a little bit about Dr. Greenberg. She's a licensed naturopathic doctor, and she's also a registered herbalist, and she specializes in functional dermatology. She's the founder of the Center for Integrative and Naturopathic Dermatology, which is a holistic clinic that approaches skincare and hair problems by finding and treating the root cause. She's also the founder of rootcausedermatology.com, a medical education website that trains functional medicine practitioners on how to treat dermatological conditions using her cutting-edge approach. Dr. Greenberg holds degrees from Northwestern University, Stanford University, and Bastyr University. She's currently co-authoring on a book on psoriasis that's going to be published next year in 2025. She teaches dermatology classes at several naturopathic medical schools and is a highly sought-after keynote speaker at conferences across the US and internationally. So maybe some of you have heard her speak already. And of course, if you're ready to start using Dutch testing in your practice, sign up as a registered provider today. It's really easy. Just click the link that we posted in the chat and complete our provider application form. A member of our onboarding team will walk you through the steps to set up an account so that you can begin taking advantage of all the education and resources that Dutch has to offer. Plus, being a registered provider, you're going to gain access to the Mastering Functional Hormone Testing course, the Dutch Interpreter Guide, and of course, one-on-one consultations with Dutch clinical educators. This dedicated support and education is designed, of course, to help you become the hormone expert. If you have any questions as we go, please submit them and we'll do our best to address them in a follow-up in the days ahead. So be sure to follow us across all social platforms to stay up to date. It's really a pleasure to have you with us today, Dr. Greenberg. A lot of us are a fan of your work, so we can't wait to learn from you today. Take it away.
Thank you so much for having me, and thank you all for joining today. So today we are going to be talking about treating the root cause of acne, and we're going to see the gut-skin connection with acne. Of course, we'll be talking about hormones as well, but we'll be diving into, I think, something a little bit different that maybe you haven't seen before. You already got this great information from Dutch, so I will skip all of this. All right, so let's talk about acne. And in order to treat the root cause of any disease, we've really got to go to the pathophysiology, what's actually happening in the body that's going wrong. And that's going to tell us how to start getting to the root cause. So let's look at what's happening with acne. The pathophysiology of what's going wrong is actually very well understood. So we're starting in picture 1 here, and we see a hair follicle, and then we see that sebaceous gland, which is a gland that produces oil or sebum. And that is the kickoff point of acne. There's an overproduction of sebum or oil that's going on due to overactivity of the sebaceous gland or the sebocytes, the individual cells within the sebaceous gland. The second point is we can get excess skin cell proliferation. So we're just getting too much oil and too much skin. And that's going to cause this gummed up or clogged hair follicle. And that is a good stage for overgrowth, either bacterial overgrowth, which we normally think of acne as a bacterial overgrowth. So there's C. acnes or Cutibacterium acnes. This is the same organism as P. acnes or Propionibacterium acnes. It was just renamed. So if you see P. acnes or C. acnes, it's that same bacteria. But there's also fungal overgrowth that can occur of Malassezia yeast. Malassezia is a commensal. It's on the skin. It feeds on sebum. So it can be either a problem or somebody can have both at the same time. So let's talk about triggers kind of versus root causes. I think about triggers as things that can make the acne worse. But if we take that away, it doesn't necessarily clean up the acne. We're going to be talking about our Western diet, which is very heavy on meat, wheat, dairy, and sugar. And we're going to look at the mechanisms for how our Western diet is driving acne. Also, excess hormones, of course, things like testosterone and insulin. We'll be talking about that. Pressure. There used to be something with high school wrestlers, they would get shin strap acne. But thanks to COVID, we now know about maskne, which is people are getting acne under their masks, which was a real thing. Medication, so birth control pills can either help or sometimes bring on acne, and steroids are known to cause acne. Stress, like I think every inflammatory disease, we know that stress will make acne worse. Substances or vitamins like too much fluoride, vitamin B12, or biotin can be a trigger. And then comedogenic cosmetics, things that we put on the skin that can clog the pores. These can all be acne triggers. So we can see that acne is pretty complicated. But that still doesn't get us down to the root cause. So let's talk about a pathway in the cell that's responsible for growth. And that's the mTOR pathway, mammalian target of rapamycin. And there are two complexes to this pathway. We know more about complex 1 than complex 2, but they're both responsible for cell growth and cell metabolism. And in particular, mTOR is responsible for lipid synthesis and metabolism. So I think sebum, that first kickoff point in acne, and protein synthesis, that is skin cell production. So the first two kickoff points in acne, overproduction of sebum, overproduction of skin cells, is due to mTOR being out of control. There's always a balance. We want the right amount of growth. We don't want overgrowth in the body. And when mTOR gets out of control, that is the driver of the kickoff of acne. And let's look at mTOR within the cell. So here we have the phosphobilipid layer of the cell wall. And here we are in the cytoplasm, and here we have the nucleus. And then outside here is outside of the cell wall in the body. So we can see mTOR complex 1 and complex 2. And there's a lot of things from outside the cell that can be impacting mTOR that might push it too far and make it go crazy. We see insulin or insulin-like growth factor. Those are signals to the body that there's excess and it's time to go grow things. So that's going to push on mTOR. Growth factors of things like puberty, right? Puberty is a time of growth. That's an mTOR going forward. Glucose, again, is an excess in the body, a signal that it's an anabolic time. Let's go build things. In particular, the amino acid leucine is a trigger of mTOR. And inflammation, things like stress or inflammation in the body, is going to trigger that mTOR pathway and make it go out of whack. And we see something else on the side, FOXO1. And we see the FOXO1 can do a dance. FOXO1 can be in the nucleus or FOXO1 can be in the cytoplasm. And this is going to be very important because FOXO1 is the balancer to mTOR. They are yin and yang. So mTOR is growth and FOXO1 is going to balance that out. Some of the functions of FOXO1, if you've never heard of it, it will inhibit that hepatic IGF-1 or insulin-like growth factor from the liver, inhibits lipogenesis, sebum production, suppresses androgen signaling. So signals from testosterone, it's going to kind of inhibit that from pushing mTOR too far, reduces oxidative stress and inflammation, and controls antimicrobial peptide synthesis on the skin that will help fight things like Malassezia yeast and C. acnes. So in the battle with acne, mTOR is your friend, and FOXO1 is your friend, and mTOR is not really an enemy because we need growth, but when it gets out of control, that's really where the problem is. So FOXO1 does a very good job of controlling mTOR when it is in the cytoplasm. So we saw that dance. We want FOXO1 in the nucleus, not in the cytoplasm. So we can see FOXO1 here is active. It's phosphorylated. It will downregulate mTOR and control mTOR's genetic expression as long as FOXO1 is in the nucleus. But when it becomes phosphorylated, it gets kicked out into the cytoplasm. and it's inactivated. It's like a penalty box. And when FOXO1 is in the cytoplasm, it cannot do anything to regulate mTOR. So that's where mTOR is going to get out of control. It's like teenagers by themselves in a house, throwing a party, right? It's pretty easy for things to get out of control. And that's what happens with mTOR when FOXO1 is not there to control it. Now, let's talk about the prevalence of acne. I think when we say acne, we think of teens, and that makes sense because, it's very prevalent in at least American teens. Up to 85-90% of teens are going to get acne. It's a time of puberty, it's a time of growth, so mTOR is already overactive. When I was growing up, really acne was a teenage problem. It was very rare for adults to have it, and it just wasn't really a thing. But that is not true anymore. There's a huge amount of adult acne now. 65% of adult females report onset of acne prior to menstruation. It's not just women. Men and women ages 20 to 40 report low-grade persistent acne, up to 55% of people. And even women in their 40s are still dealing with acne. So it is no longer just a situation where it's a teenage thing. A huge number of adults have it. I probably treat more adults than teens even. And a lot of adults are very frustrated because they didn't have it as a teen, and now they have adult acne, and they're like, this doesn't make sense. Why do I have acne in my 20s, 30s, 40s? This shouldn't be happening. So with numbers like this, it makes it feel like, all right, I guess acne is normal. And if we think about all of us who are on this webinar right now, how many of us have never had a zit? Probably no one, right? It's pretty pervasive in our culture. That makes it feel normal. But there's a difference between something being common and being normal. And what really blew my mind, I completely changed the way I thought about acne, was looking at research on indigenous societies and their levels of acne. So there were some studies done, and these populations, again, are non-Westernized societies. They are living in like the Amazon rainforest. They're hunter-gatherers. The Acne people of Paraguay were studied. This was a tribe of 115 individuals. Researchers looked at this group over an 843-day period, so 2.5 years. And they could not find a single zit, no papules, pustules, or open comedones on anyone in the tribe. There were teenagers, there were menstruating females, but nobody had acne. Then they looked at Okinawa prior to World War II. So Okinawa is the southernmost island of Japan. And back before World War II, this was a very isolated, indigenous lifestyle type island. And they asked the physicians there who had practiced on the island between 8 and 41 years all about acne. What's the prevalence? How are you treating it? And the doctors across the board were like, there is no acne. We don't treat it. The Kitavan people in Papua New Guinea were studied. This was a group of 1,200 individuals, again, very rainforest, indigenous lifestyle. And they were studied over 7 weeks. And if we were in a room, I'd ask you to shout out, what do you think they found? But I think you can guess. They did not find any acne in 1,200 people. So what is going on? Is there something genetically amazing about these groups? And the answer is no. When people living in indigenous lifestyle move into urban areas, they can and do develop acne. So there's nothing genetic. It's a Western society lifestyle issue. And in fact, these people, they've never seen acne. They don't have a word for it. So it is not appropriate to say that it is normal for humans to have acne, even teens, because it's not. It really is a function of our Western lifestyle. And that brings us back to the story of mTOR, right? As we said, for example, in puberty, yes, mTOR is going to be upregulated. That's a period of growth. But that doesn't mean that you need to have acne, because mTOR should still be in balance. What's happening in our Western lifestyle that could be throwing mTOR out of whack? Well, certainly what we're eating is very, very different from indigenous cultures. The 4 things that we really love in our Western diet are meat, wheat, dairy, and sugar. And in general, these are things that are either not really present or found in appropriate amounts in indigenous diets. So meat, I think eating meat is completely appropriate. But in the Western world, we eat a lot of meat. It's often not healthy meat. It's been raised on antibiotics and hormones. And that crowds out fiber and vegetables from our diet. So meat is heavy in leucine. That was one of the amino acids that was a heavy driver of mTOR. And wheat and dairy are also high on leucine. So 3 of these things are high on leucine. That's going to trigger mTOR. Dairy and sugar trigger insulin-like growth factor 1 and insulin. And of course, sugar is glucose. So all four of these things that we eat so much of is going to push mTOR over the edge and make it go out of whack and drive acne. An indigenous culture is very heavy in plants and fiber. That's the opposite. That's anti-inflammatory. That's going to calm mTOR down. But there's a lot of influences on our gut microbiome, right? We talked about the diet, but we're on a lot of pharmaceuticals. Where you live in the world and where you are in your life cycle will impact your gut microbiome, how you were given birth to. So if you were a C-section, where you fed formula as a baby, and it's our everyday stress and kind of lack of exercise in the Western lifestyle is all going to change our gut microbiome and make a very different gut than the indigenous populations have. We tend to have an inflammatory gut. They have an anti-inflammatory gut. So let's look at acne in particular. How can we connect what's going on in the gut with acne? So I do hundreds of gut microbiome tests, which we'll talk about because we're going to do a case study. And there'll be some functional medicine labs, but I do a lot of stool testing and then oat or organic acid testing, as well as Dutch testing. But in the gut, I felt like I was seeing a certain pattern in my acne patients that was very different than patients with other diseases. So for example, there is an eczema gut that I see. That was not at all what was happening in my acne population. I felt like I was seeing high levels of H. pylori, candida, and protozoa in my acne patients. So I decided to do a retrospective study and see if this was actually the case. I pulled 36 of my most recent patients in my database with an ICD-10 code of acne. That happened to be 28 females and 8 males. The age ranged from 13 years to 40 years, but the mean and median age was 25 years. And here's what the data showed. Indeed, what I thought I was seeing was happening. So 94% of this cohort had elevated or high candida. 92% had present or high H. pylori, and half of those patients had protozoa. So protozoa of any form, it could have been Giardia or, Entamoeba, Dientamoeba fragilis, Entamoeba coli, any Blastocystis hominis, any protozoa, they were put into that same bucket. And then in terms of how the population broke down, like how many did they have, 47% or 17 of the 36 had all three, and 44% or 16 had two, which were typically the candida and the H. pylori. Most of the patients with protozoa had H. pylori, and I think that is due to the hypochlorhydria that H. pylori can induce. It's very acidic in the stomach. When H. pylori dwells into the stomach lining, it's uncomfortable and it will produce substances like urease to raise the pH and make it more neutral. And that's when protozoa can come through. So across the board with my patients, I mostly see protozoa in patients who have H. pylori. Now, of course, the question is, okay, these are what we found in the 36, but how does this compare to normal healthy controls? And I tried my best to kind of try to find comps. So in published research, we see varying levels, but there was a cohort here of normal healthy controls that had an H. pylori rate of 36%. Diagnostic Solutions Labs helped me out with this data. They ran an analysis on 18,390 of their stool tests that were done in early 2021. And anyone who's running a stool test, is much more likely to have a GI disturbance. But even their whole cohort of 18,000, 65% had H. pylori. And then Biocanic is another company that aggregates functional medicine lab testing. And they had 2,940 tests, and they had an H. pylori prevalence rate of 41%. With Candida, again, my acne cohort had a 94% rate. Published research, I found 22%. The Diagnostic Solutions and Biocanic stool tests were at 25 and 21%. At protozoa, I couldn't find any published research of a cohort with any sort of protozoal infection, but in Diagnostic Solutions, 18,000, it was a 12% infection rate. Biocanic had a much smaller sample at 3,000. They couldn't explain why it was higher than Diagnostic Solutions, but this is probably a better number. So we can see across the board that the acne cohort had a significantly higher prevalence of H. pylori, candida, and protozoa than normal healthy controls, or even those with GI problems who are running stool tests. So What might be that connection with H. pylori and acne? Well, studies have been done on it. Here is one. There was a case-controlled study with 100 participants. So there were 25 control patients without acne and 75 acne patients. And the acne patients were split into mild, moderate, and severe. We can see that in this cohort, over half of the control group did show up with H. pylori. But what was interesting is the infection rates as the severity of the acne increased. So mild acne had 60%, moderate had 72%, and severe had 88%. So we cannot say that, oh, if you have H. pylori, you're going to have definitely have acne, or vice versa, that if you have acne, you definitely have H. pylori. But there is this connection that we see between acne and H. pylori. What could be going on? Well, let's go back to that story of FOXO1. So there's a whole theory now that acne may be due to the deficiency of FOXO1 within the nucleus of the sebocyte. So remember, where is FOXO1 active? In the nucleus. Where is it inactive? In the cytoplasm. So we want FOXO1 in the nucleus and in the nucleus of the sebocyte so that it can keep mTOR at a reasonable rate and not overproduce sebum and not overproduce skin. We know that Cutibacterium acnes may downregulate FOXO1, so there can be this feedback loop. Our Western diet, insulin and insulin-like growth factor downregulates FOXO1. Puberty downregulates FOXO1. So there's a lot of factors that are going on. Now, again, remember our indigenous populations. All of that still should not cause acne. But because of our Western diet, that's, I think, what throws things over and our gut microbiome is off. Now, I looked for research to see if there was any connection with sebocytes. I couldn't find it, but I did find a study that showed that H. pylori infection induced nuclear inactivation of FOXO1 in human gastric cells. So in the stomach, H. pylori is kicking FOXO1 out of the nucleus and sending it into the cytoplasm, inactivating it. Again, I can't find any research right now that was done on H. pylori's effect of FOXO1 within the sebocytes, but I don't think it's outrageous to think that this could be the connection between acne and H. pylori. So, of course, the goal of naturopathic and functional medicine is we want to find and treat that root cause. We don't want to just suppress symptoms. With acne, there's a lot of symptom suppression. The woman, you can go on spironolactone, you can go on birth control. There's oral antibiotics for everybody. There's a lot of topical antibiotics and harsh things like retinols to dry up the skin. And then in the worst case scenario, there's isotretinoin, which we used to call Accutane, but people still call Accutane, which is a pretty toxic drug. If you are a female on Accutane or isotretinoin, you have to take a pregnancy test 1 month before, a pregnancy test every month you're on it, and a pregnancy test the month following completion, and pledge that you're going to use 2 forms of birth control because it is so toxic. It's teratogenic, meaning that if there's fetal development while someone is on this drug, it's going to have tremendous amount of birth defects. If it's that toxic on a developing fetus, do we still want it on our developing teens? Probably not. So symptom control is obviously not the goal for functional medicine or naturopathic medicine. We need to get down and find those root causes. And that's what we're talking about, is those impacts on mTOR and subsequently what is going to happen in the gut microbiome. So gut dysbiosis really is a trigger for systemic inflammation. I think we know this across the board for other conditions like heart disease, or strokes, so diabetes. We know this connection, but sometimes we forget that these derm diseases are chronic derm diseases. They are inflammatory diseases, and they are also driven by gut dysbiosis. So really, testing and treating the gut is a fantastic way of getting at the root cause of acne. So let's talk a minute about the gut microbiome. The average human has 3 to 5 pounds of microbes in their gut. And we house and feed these organisms for free. I think this is kind of astounding when you think about it. It's like a hand weight. That's a lot to be carrying around and feeding. Why are we doing this? Are we just benevolent creatures? What do we get out of this arrangement? Well, of course, we have co-evolved together. We can't survive without them, and they can't survive without us. And they make things that we need, like butyrate or vitamin B12. We feed them fiber, and they give us postbiotics or these metabolites. But they also crowd out pathogenic microbes from taking root in our gut, and they maintain a healthy ecosystem in the gut, and they maintain a healthy immune system, right? They are anti-inflammatory, and acne is inflammatory. We have trillions of organisms that live in the gut, everything from bacteria to fungi, viruses, archaea, bacteriophages, protozoa, and worms. The ones in the greatest amount are bacterial, but all of these organisms are living in us, possibly, and impacting our health and our gut microbiome. So testing and treating the gut, I'm going to start with looking for digestive function. The mouth, the oral microbiome, is the start of our digestive tract, and we swallow about 2,000 times a day, about 1.5 liters of saliva. So what's going on in the mouth has a huge impact on what's happening in the rest of the digestive tract. And I ask my patients, do you floss? How often? How often do you see dentists? Do you have cavities? Do you have root canals? This is really important to know what's happening in the oral microbiome. But I'm also looking at the gut microbiome, the small and large intestine. Of course, we've got H. pylori that can colonize the stomach, and then a lot of bacteria living particularly in the back end of the colon. And I need to see, is there enough good microbes? Are there too little? Are there too many bad microbes? Then I know how I need to go in and fix the gut dysbiosis to create a calm situation and clean up the acne. So functional medicine tests, you guys are here on Dutch, so I'm sure you guys use the Dutch test, but there are many. As I said, I do a stool test and an organic acid test, kind of standard on every patient. And then I do a lot of Dutch hormone testing as well, also for sure for acne, because the hormones obviously do play a role, and knowing what's going on can be very helpful in treating your acne patients. And then I use the lab tests results as my roadmap. I know where I'm starting. I've got a lot of acne. I want to clean it up. I want to get them to clear. And the way I'm going to do it is by cleaning up all the issues that I see on the functional medicine tests that I run. So let's look at a case study, and we're going to look at a 30-year-old patient. We're going to call this patient Emerson. This is not their real name. Emerson is a 30-year-old non-binary individual. She was assigned female at birth. Her preferred pronouns are she or they. She started getting acne when she was 11 years old, but it got really bad starting 3 months ago. It was bad many years ago in high school, but it's never been this bad. And they have painful nodules and said, I don't feel comfortable in my own skin. And this patient has a history of suicidal ideation and depression. And they're really worried that if they don't fix this acne, that it could put them over the edge again. So I want to stress that for your patients with acne, this is not just a cosmetic issue. It's painful. It's showing an inflamed system. And people really are affected by this emotionally and psychologically. And there are higher levels of depression, anxiety, suicidal ideation, and suicide amongst people with bad acne. And it's really hard when you have something on your face. It's the way we present to the world. And I just want to stress that this really is not just a vain cosmetic issue for people. It's something to be taken seriously. And cleaning up acne for them really can be life-changing for them. So they started seeing dermatologists at the age of 12 and have been seeing them ever since. Currently, before they tried clindamycin, which is a topical antibiotic, salicylic acid, benzoyl peroxide, tretinoin, which is topical retinoids, adapalene, tazarotene, retinols, glycolic acid, lactic acid, natural products. They've tried everything. Orally, she took antibiotics or doxycycline for 3 months. Doxycycline is a tetracycline, and it's one of the most commonly prescribed antibiotics. Minocycline is another one. They did it for 3 months. It did get, but that one didn't work. And then she did Accutane or isotretinoin, but she could only do one course. She had to cut it short after 4 months because they felt their mental health was being affected, although the acne was better. Also did spironolactone at 200 milligrams, which is pretty much the highest dose for 2 years, and help but discontinued for side effects. And a lot of patients, the spironolactone is only for those female at birth who want to be female. It is a androgen receptor blocker, but it also can lower blood pressure and cause dizziness and all sorts of side effects. So I have a lot of patients who've come to me. They've been on spironolactone, maybe it worked, but they've had to discontinue because of the side effects. Or again, they don't want to stay on suppressive medication. They want to know, what is wrong with me? Why is this happening? I want to fix this at a root cause level. So right now they are on Serotin cream. They have also been diagnosed with PCOS and hirsutism, which are obviously hormonally implicated. So for this patient, we did the GI map stool test, the organic acid or oat test, and a Dutch test. And we're going to look at the results of all three. Okay, so this is that patient at the first visit and just showing you the severity. This is very inflamed acne. And now let's look at the gut microbiome results. Okay, so this is one where we can see no H. pylori showed up. And for me, this is immediately a sign where if I hadn't already run a Dutch, I would immediately be running a Dutch at this visit, because it is pretty atypical for me to not see H. pylori. And then I know, like, for sure the hormones are completely out of whack and I've got to go see what's going on. But like I said, we ran a Dutch from the onset for this patient. We already knew that there were problems with the PCOS and the hirsutism. Hirsutism is unwanted hair growth in places it shouldn't be. The normal bacteria flora. So these are the commensals. And overall, they actually looked pretty decent. Akkermansia muciniphila is missing. Akkermansia muciniphila is a keystone species. It helps maintain our gut mucosa. So when I see that, I do get worried that there could be a leaky gut. But the rest of the commensal bacteria actually look pretty good. Now we go to the opportunistic or unwanted bacteria. And we can see that there is an overgrowth of some organisms here. There's high Enterococcus faecium and high Staph aureus and Streptococcus. Staph aureus and Streptococcus are the two most common elevated or high findings in this opportunistic section, but we want to get this all into balance. And then we can see that the Candida was quite high on the stool test. So 3.66 E4 means 3.66 times 10 to the fourth power. So if we move the decimal point 4 places, this value is 36,600. Normally, I don't want to see anything here. It's typical for me to see this symbol, which means below detectable limits. The lab is saying, okay, there's a cutoff of 5,000, but again, when you run a lot of these tests, you know what's normal for you and your patients. Usually it's a 0. So 36,000 is a lot of Candida overgrowth. This is the oat organic acid test. Arabinose is the marker for Candida. We see that this is on the cusp of high. But the fact that it was high on the stool test for me is pretty significant because I usually don't see it. So there's fungal overgrowth. But then we also see this tricarbonylic acid, and that is an indicator of Fusarium mold overgrowth. So there's not just Candida, but there's additional fungal overgrowth that we need to deal with. Then on the Dutch test, we see this is kind of a snapshot. So we're going to delve into it, but I think you guys are probably, more savvy crew when it comes to the Dutch. So this is that snapshot, right? If you're new to it, this dial will show you what the premenopausal range is. This patient is premenopausal, is not on testosterone or any hormones. So the female at birth is, the female hormones should be coming through normally. So we want to see it on the green dial somewhere between these two stars. If we see it down at the purple, that would be a postmenopausal female. And then when we see the dials, the red beyond this high limit, then that's a high number. So we're going to be looking at the estrogens, the progesterone, the androgens, and the DHEA and the cortisols. We're going to do a deep dive. But we can see from a snapshot, this cortisol is very high, right? It's elevated all the way through. So they have a rising and falling pattern, which is what we want to see. But it's just from the get-go, it's high and doesn't come back down until evening. So a lot of too high cortisol. They're trying to metabolize it, but there's too much to really get it down to normal range. And the DHEA is high. And their age is 30. So we would want to see DHEA between 1,300 and 3,000. But we can see we're up at 5,755, which is too high. Okay, so let's do a deep dive. So we're looking here at the progesterone. So the progesterone is, too low. This was a good sample. It was collected at the appropriate time. They may or may not have ovulated, but also the ratio between progesterone and estrogen. This is an estrogen dominant picture, which is not unusual for a PCOS. The estrogen, so the estradiol is normal. This is the main hormone of menstruating females. And the estrone and the estriol we can see are a little bit low, but the estradiol is good. But the ratio of estradiol to progesterone is off. It's an estrogen heavy picture. We can see here the 4OH pathway. They're at 12.4%, which is a little high. We'd like to see it in the 7.5 to 11% range. The issue with so these are how we break down and metabolize the estrogen. The problem with the 4OH pathway is that it can turn into a quinone, and that's a reactive species that can cause DNA damage and ultimately lead to things like, breast cancer or unwanted things. Now we can kind of deactivate this pathway with something like glutathione. So it's not necessarily the case that there's DNA damage being caused, but I like to pay attention when it's out of range and support, a more healthy way to metabolize the estrogens out. For the androgens, we saw that the DHEA was high from the first page. The testosterone is very high. So if we look at testosterone for the age range, she is again 30. We'd want to see between 3.2 to 14, and they are at 20.33. So a very high testosterone. And the breakdown, we can see a very high 5-alpha pathway and a 5-beta pathway that's high. But even though the pathway isn't showing that she's preferring 5-alpha, there's so much testosterone that it's a concern, this 5-alpha pathway causing things like acne and hirsutism, and the high DHEA is also a potential trigger of high acne as well. So we can see that there's some androgen problems here. And again, the age ranges down here for the DHEA sulfate, the androsterone, and the eticolanine you can look up the values, but she's high on everything. When we pull out the table for the androgens and metabolites, we can see, I like to look at the 5-alpha DHT. DHT stands for dihydrotestosterone, and it's a supercharged form of testosterone that's like 8 times as potent. When we have high DHT, that is a definite signal that is responsible for, that's a 5-alpha pathway, and it's responsible for things like the hirsutism, acne. It can be responsible for hair loss in places where you want it, like the scalp. So we can just see a whole bunch of above ranges and high for all of these androgen metabolites for this patient. The cortisol, okay, we also talked about the cortisol. So the free cortisol is high pretty much all day until the night. And the free cortisone, which is the inactivated portion, is high as well. The body's trying to inactivate it to pull this down, but even with all of this high cortisone, they're still having high cortisol throughout the day. So there's just a lot going on for this patient hormonally. And this is an example of why running the Dutch. Now, I will say that I think when people think of acne, they're thinking, okay, I'm always going to see high androgens, but that is not the case. I've seen all sorts of issues with my acne patients. I've seen low estrogen. I've seen low progesterone. I've seen high estrogen. You really need to test I will never treat hormones unless I run the Dutch and I know exactly what is going on, because you can't make the assumptions. There's so many times where I've been like, wow, that was not what I was expecting to see. I'm so glad that I had the data to go ahead and do the right thing. In this case, yes, there's a high androgen level, and I was suspicious of that, but it's good to see it, because if that's not the case and you go after lowering androgens and the androgens are already low, right, then we're doing more harm than good, and that's not what we want to see. So there's a lot to go after here for their hormones. Okay, so when we kind of like put together all of the test findings, like what do I need to do to help this patient get over this acne and treat the root cause? We've got bacterial overgrowth of dysbiotic bacteria like Enterococcus faecium, staph, and strep. Potential leaky gut, there's no akromansia. We know that there's fungal overgrowth of candida and fusarium, and a lot of hormonal issues, high testosterone, high dihydrotestosterone, high 5-A androstenediol, DHEA, DHEA sulfate, cortisol, cortisone, and a low progesterone picture. So a lot of things to be done. Okay. The first thing I'll say is that this is, of course, naturopathic medicine. And in naturopathic and functional medicine, right, we always treat the individual. So this is not like the treatment plan for anyone with acne. This is the treatment plan for Emerson after doing the functional medicine testing and seeing exactly what's going on with them. And for me, I see patients on average every 2.5 months, and the treatment plan will change each time I see them. So this is not going to be, everything you see here was not done all at one time. It was done over the course, but we're going to see the picture progression as we go. And you'll see from visit to visit what progress was made. For bacterial overgrowth, I love antibacterial herbs. There's a lot of different ones with, a whole slew of them. For antifungal herbs, these are some formulas that I use, but I use a ton of formulas. I also use Biocided. I use Beyond Balance. I use Ayush herbs. For no akkermansia, there's an akkermansia probiotic. For low commensal bacteria, I talk with all of my patients about getting 35 grams of fiber a day and 30 plants per week. So we really want to build out that diversity and volume of fiber. Fiber is what maintains the healthy gut microbiome. They eat it for food. I do probiotics as well. I really like Biocidin's ProFlora 4R. There are pomegranate formulas. For example, Pure and Cap has a polyprebiotic powder. So the pomegranate feeds those commensals. So we really need to support the commensal bacteria and make sure that the akkermansia and all of the bacteria are getting support. For high androgens, I did do 5-alpha reductase inhibiting herbs. So that's that 5-alpha pathway. Things like saw palmetto, pygeum, and nettle root are great options. For high cortisol, I did cortisol balancing herbs like holy basil, rhodiola, and ashwagandha. And for topicals, I do use botanical topicals that are going to help reduce the sebum production and heal the skin. There's kind of two phases with the acne treatment. First, we want to get rid of the acne, but a lot of times there's residual damage called PIH, post-inflammatory hyperpigmentation, and then there's scarring. And then once the acne is gone, patients are really concerned about those issues. Okay, so let's take a look at the progression over time. So this was the first visit where we see the inflamed acne. This is at the 2-month mark. And you may be thinking, well, I'm still seeing a lot of acne. Yes. But what I like to tell patients is we are turning down the dial on the sebum production. There's no way to just kind of wave a magic wand and make the acne disappear. It's really a process over time of turning it off and working it down. Again, we're working at these root causes. And this is actually exactly what I want to see. So we see here at the beginning that there was the puffed up, red, actively inflamed acne. Now we can see that it's gone down. It's flattened. It's more kind of like the scabs. Every time this is what I want to see is this more kind of scabbed flat acne. This means that the inflammation is turning down and the sebum production is turning down. Here we can see starting to repair skin. We do see an inflamed lesion here. So it's not always a straight line. It's not just like we're never going to see an inflamed, pimple again. It depends what people are doing. What are they eating? Are they following the plan? Are they on vacation? But we can still see that there's been tremendous improvement in 4 months in terms of the amount of inflammatory acne and also the healing that their skin is going through. At the 6.5-month mark, we don't really see any active acne at all, but we are seeing a lot of that scarring and post-inflammatory hyperpigmentation. And as I mentioned, this patient really, struggled with some mental health issues before, and they were so scared about the acne coming back that they really wanted to stay with it and treat for a long time and clean up the skin and not worry about it coming back. So you're going to see now that most of the time I'm treating this patient, there's not going to be active acne, but we're still going to be treating, cleaning up the skin and making sure that all the issues are gone. Because at the beginning, when I was starting to develop these methods and I would see the skin clear, the minute the skin would clear, like here, I would think, oh, we're done. The skin is clear. There's no more acne. Okay, we're done. What I didn't realize is, there's that proverbial bucket, right? Where our system, filling things up with things that are not good, whether it's eating badly or drinking alcohol or pollution or H. pylori. And then at some point, the bucket gets full and overflows, and then we see problems like acne. I was lowering the bucket kind of right below the lid when I would stop right here. And then I learned that I needed to really treat to clearance of the underlying issues. So sometimes I'll do retesting. It's up to the patient. This patient didn't have a lot of money, so we didn't do the retesting. But I know now, right as soon as it clears, we're not low enough. We haven't drained the bucket enough. It's just going to come back in 3 to 6 months. So I keep treating. Now we can see the progression as we go from visit to visit. And you can see the skin is really starting to heal. So these deep divots and scars that we saw are really starting to clean up. And, this is a 30-year-old patient. At any age, I've seen the skin heal and really do great things. So by the 18.5-month mark, the patient finally felt confident enough to go on their own. And, I haven't heard back from them. So that's a good sign. It's been a couple of years. And, we can really see the difference in the skin here. And it's because we went after the root causes and we cleaned up what was going on. We were not just suppressing symptoms. This is just the other cheek. So we can see, actually, the second visit, it almost looks like it got worse. I don't freak out too much about that. The other side was doing better. And there's still, there's a little bit more. It's still not as inflamed as it was. But with the other side doing better, I knew that we were on the right track. This was the worst side. But we can see, again, the same thing. Oh, sorry, it's out of order, the animation. But you can see that, the skin is basically, cleared up and healed also in that a year and a half, even at 30 years old. So here's kind of the before and after, and this side before and after. So what are things to consider if you're treating this way? Well, if you're thinking of treating the skin, think of the gut. Of course, with acne, think of hormones. I think, that goes without saying. You'll have to analyze all of the problems that you'll need to address on all the work that you do. And you have to decide what order you want to treat them in. Don't try to treat everything all at once. That is going to be counterproductive. And then adjust based on the patient. So, obviously it's not going to be an infant with acne, but is it a teen? Is it an adult? Is it a breastfeeding mom? What type of patient are you treating? And then for me, I move through different protocols every 2 to 3 months. And like I said, treat beyond skin clearance. The minute skin clears, it's not over. You have to keep treating until you've really lowered that bucket. And I'm also teaching the patients during this time how to, eat 35 grams of fiber a day, 30 different plants a week, and maintain this. I take out dairy for pretty much all of my acne patients, and, really working on reconstructing a diet that's not our sad standard American diet, but a much more healthful diet. So does this type of methodology work for other derm complaints? It does. I treat all of my patients this way. Here you see some very nodulocystic acne. Here you see severe eczema. This is infant eczema. It's always on the cheeks. Another patient with eczema. I don't know why I have frozen. Okay, there we go. This is a teenage eczema with lichenification or thickening of the skin on the ankles. Hand eczema. It was really a big deal in COVID, but there's still a lot of hand eczema out there. Eczema herpeticum. This is psoriasis. I treat the same way. You can see you can get very extreme to clearance. This was a different patient with almost an infected psoriasis. Guttate psoriasis or the spot psoriasis. This is a palmoplantar pustulosis. Sebderm, alopecia areata, and hair loss. All of these conditions I treat in the same way. So if you are interested in treating derm in this way, I have a root cause functional dermatology course. The next course is going to be starting November 3rd. So they are cohort-based 4-month courses for licensed healthcare providers. It's really a comprehensive course. So I'm going to teach you the advanced functional medicine lab training, how to analyze a GI map stool test in relation to all these conditions, an oat, a mycotoxin, the Dutch, how to treat gut dysbiosis. How do you clean up the H. pylori and the SIBO and the Candida? With the Dutch test, what are you going to do for high or low cortisol? What are you going to do with high testosterone or low estrogen, or, supporting the pathways? That's all part of the foundational functional medicine lab training. And then we delve into the 7 most common derm diseases that you'll see. And even if you're more of a primary care practitioner, you're going to see derm, because the number one reason why patients go to see a doctor is for dermatologic complaints. So we go through acne, eczema, seborrheic dermatitis, psoriasis, rosacea, hair loss, and keratosis pilaris. And each disease has a whole extensive drill down on the pathophysiology, more than I could share with you today. And then there's 5 case studies for each one. So for example, with this patient, instead of seeing kind of general stuff that I would be doing, you're going to see the exact treatment plan, both oral and topical, that I gave this patient at each visit, and learn how to construct a plan and how to move a patient through plan to get them to clear for 7 of these different diseases. There are different ways to do it, and very different topicals to use. So you're going to learn both oral and topical. It's because a skin issue is almost never just a skin issue, right? It's not skin deep. We've really got to go deeper. You can get more information at Root Cause Dermatology. There are 2 courses. So the live 4-month mentorship cohort course is what I was talking about. That's the one that's starting November 3rd. It's a 4-month intensive. There's recorded content each week that drops. And then we meet up every other week in a live session, and we get together, and there's a lot of clinical pearls and case studies, and you guys can bring your patient in as a case study. I go through how to treat via telemedicine, because I'm 100% telemedicine, and it's a great business model for chronic derm. I go through my business model in one of the mentorship courses. And one of the best things is that there's a Find a Practitioner database. So once you've completed the course, there's quizzes at every module and then a final case study. You can be listed in the Find a Practitioner database, and the alumni are getting tons of patients out of it. And many alumni have told me that the course actually paid for itself through the referrals that they're getting through the Find a Practitioner database. So that's for licensed healthcare providers. And you can download the PDF here and get more information. Here's the degrees that are accepted, but if you can't read it, just download the PDF. The self-paced course is for healthcare professionals who can order functional medicine tests like the Dutch, but you're not licensed by a government body. So the 4-month mentorship, you must be licensed and overseen by a government body. The self-paced course you can do if you are a healthcare professional who can order labs, but maybe like a functional nutritionist or something. And that is all I have for today. So I want to thank you for joining, and thank you so much to Dutch Labs for putting this together and allowing me to talk to you today.
Thanks for joining us, Dr. Greenberg. That was an excellent webinar, and I feel like a lot of us feel a lot better equipped when it comes to assessing and treating our patients with acne. And thank you to the listener for joining us today. We hope you learned something helpful in all things acne and skin health. Watch your inboxes tomorrow for a link to the recording and to access the resources we shared today. You can learn more about the research behind the Dutch test at dutchtest.com/research. And of course, make sure to visit the Become a Provider tab at dutchtest.com to register for an account so that you can gain access to even more hormone education and research. Be sure to follow at Dutch Test and subscribe wherever you get your socials to stay in the loop for upcoming webinars and podcasts.